Okay, so we're talking about community services for self-harm now. And what you'll get over the next kind of 40 minutes or so, I'll give you a bit of general kind of context, which will be familiar to many of you. I'll then talk specifically about the current kind of programme, because there's a little bit of confusion about where this bit of work actually fits in with all the many other bits of work that you're all up to. I'll talk about the importance of settings for self-harm services. So, you know, your offer in different settings. Yes, it's not about just the acute hospital setting, community settings, you know, a third sector and voluntary sector colleagues. So settings are really important for self-harm. A little bit about the research evidence and what it tells us about how we should best help people who self-harm. And then lastly, because we're asked about it more or less all the time, is self-harm in the pandemic, and how things are going to evolve in terms of services and the impacts really specifically on self-harm. So let's talk a little bit about context. I'd like to start with a bit of historical context, and it's a bit of an uncomfortable reminder to me that I've been working in this area for 25 years. So for 2.5 kind of decades I've been working in the area, and I actually started with this fellow here, Alan House, former professor of liaison psychiatry over in Leeds, and back 25 years ago things were in a bit of a kind of dire state, I'd say, with respect to self-harm services. Lots of variability. Over the last kind of 25 years, I think there's been a bit of a kind of divergence of opinion about how things have gone. So this was a pair of editorials published in the British Journal of Psychiatry. We've included the links on all the slides, so you can you know, click on them if you want kind of further details. But Alan's view is that things, you know, really haven't got any better in the last 25 years. You know, I think our view, my view, is there's lots of activity in the area of self-harm. We're doing lots more than we did, and things have improved. It's still, there's a long way to go, and that's partly what this programme's about. But I think we've come a fair way in terms of progress. And self-harm's never had a kind of higher profile. You know, we've got various reports from, you know, Parliament, from the Royal Colleges, from NICE. You know, we're redoing the NICE self-harm guidelines at the moment, and hopefully they'll come out later in the summer. So lots of activity in the area. I'll talk about this report. It's had a really sorry, my audio's just gone funny. I'm hoping you can still hear me. Can you still hear me, Caroline?
Yeah, it's fine now.
Okay, it's just that I've got a flash up saying my microphone was no longer working.
It was just a second.
Right, okay. So what we're talking about when we talk about self-harm, I mean, it's a lot, you know, all of you all know this, but it's both self-poisoning and self-injury. In hospitals where I tend to work, it tends to be mostly self-poisoning, but in the community, it's mostly self-injury, particularly self-cutting. But it's irrespective of apparent motivation or medical seriousness. So, you know, in the UK, we tend to operate this intent-free definition. We don't often talk about attempted suicide versus non-suicidal self-injury at NICE in research. And the reason for that is that, you know, clinically often it's very difficult to distinguish. There's, you know, people don't fall into these clear groups all the time, and people shift. So motivation shift, intent shifts. And we know that people, you know, even people who are kind of labelled as having non-suicidal self-injury, when you follow them up, are at increased risk of suicide. So we have this kind of intent-free definition. And there's a lot of it about. So it's one of the commonest reasons for hospital admission. 220,000 episodes, over 150,000 people presenting in England every year. So common problem. So it's a common problem. You know, a lot of the workload of liaison psychiatry teams, a lot of the workload of emergency departments, a lot of the workload of community services. But the other thing, of course, is that it's associated with suicide. So this is a paper we published on older people, and older people who self-harmed were about almost 150 times more likely to die by suicide than older people in the general population. This is also a reminder that self-harm can occur anywhere across the lifespan. So sometimes when you talk about self-harm, people think, it's a problem predominantly of the young, and it is more common in young people. The peak ages, late adolescence, early adulthood, in terms of the peak incidence, how common it is, but it can occur at any time. And certainly in older adults, one of the things we're worried about is this link with suicide. And also thinking about, the role of mental health services. Older people in particular, you might think there's a bigger role for mental health services. Only 12% were referred in this study. But I think what we're not saying is management or what helps is the same for everyone, for every age group. So for older people in particular, there are other things you might want to be thinking about: the role of physical illness, bereavement, and social isolation. Probably, formal psychiatric disorder is a bigger factor in older adults who self-harm. So it can occur anywhere across the lifespan, self-harm, and the important thing is the association with suicide. So you've got this common problem leading to potentially very serious outcomes. How do we do in terms of services? So this is that Samaritans report I was telling you about, and the title kind of sums it up really: pushed from pillar to post. So the idea that existing self-harm services can be rather fragmented. This is kind of patient pathway: someone referred into the GP, referred back because they don't quite meet the criteria, not getting access to kind of talking treatments. This idea that services are fragmented, and we need to improve our offer for people who self-harm. And that's really where this current program comes in, to try and improve all of that. So it's actually part of flowing from the NHS long-term plan. It's part of the community mental health kind of transformation, which I'm hoping all of you, very, very familiar with. For those of you who aren't, that's a major investment in mental health services. And really the key bit of that is trying to integrate models of primary and community mental health care. So this idea that there will be, for someone presenting with mental health difficulties, mental health problems, there'll be kind of, if you like, seamless care, and we'll avoid some of that fragmentation that we've already talked about. So it's part of that community transformation work, and specifically this bit of work we're talking about today, what NHS England are asking you to do is think about your plans for how you manage self-harm in the community. So many of you have already got very, very active work streams in this area, and it's really a question of kind of marshalling those together and seeing how they fit. But really that's the ask here. There's been a bit of confusion. Some people have said, well, we've got no funding to do this. I mean, I think the very strong message from NHS England is actually this is part and parcel of the community transformation work. So in terms of resource, in terms of effort, in terms of staffing, it really should be very much part of the community transformation work, the community services work that's well underway across the country. So for you guys, the ask is thinking about what you provide for people who self-harm. What's our role from the point of view of the Centre for Mental Health and Safety, from the point of view of the National Confidential Inquiry? Our main role is the evidence, really. So you're going to hear a bit from me about evidence today. We're also going to comment on any plans. So unlike the first phase of this work, so you're actually in the second phase of the work. There were 10 early implementer sites, and we commented on all their plans. But in this phase, really, we'll comment on the plans if you want us to comment on them. We're more than happy to give you advice, and we'll also advise on measurement. I'll talk about that in a second, and implementation. So important to have a, if you like, a plan for how you're going to implement the changes, as well as saying what changes you might have. How are we going to provide that support? Well, there's events like this, we call them kind of virtual site visits. You'll get email contact from us. There's a website which I'll show you in a second, and really this is an opportunity for shared learning. So there's only two areas here today. Sometimes we have a few more areas on these calls, but we encourage you to steal from each other. So stealing from each other today on the call, but also from the existing sites. And as well as that, Leah has, together with Caroline, organised a series of kind of interactive clinics. That's open to everyone. So everyone in the programme, all areas of the country, where there'll be a theme, generally a kind of guest speaker, and you're welcome to kind of log in and ask questions. So that's if you like our role. Here's the website that I talked about. The links will be included in all the slides, and it's got areas that people might want to look at, the evidence, any kind of relevant policy documents, and do please take a look at that. And if there are any errors, let us know. If there are any omissions, anything you'd like to see on there, do feedback, because that's a continuously evolving resource. I mentioned the importance of measurement. So you'll have a plan, you'll decide what you want to do, but really important that you kind of, if you can, collect outcome data to make sure what you're doing is effective. Obviously, the outcome data that you might want to look at is what happens to self-harm. One of the difficulties there, and if we get a chance, or if you're interested, I know Caroline can talk to this in the discussion, is it's actually really difficult to collect good quality self-harm data, because often self-harm is coded as other things, often it's kind of missed from hospital data collection systems. But there are available data that you can use, which is imperfect. If you're looking at admissions, that tends to underestimate the incidence of self-harm, but there are outcome data you can use. Things like, if you want to measure whether what you're doing is effective, thinking about, have you implemented the nice quality standards for self-harm, getting support from service users themselves, or access to services. So, if you're starting a new service, how many people are going through that service, how many people are accessing that? They're all valid ways of measuring, and measuring is quite important. Now, all of that's going to sound quite overwhelming, plans for self-harm, gosh, it's such a huge area, where do we start? In one sense, you're lucky, because this is the second wave. So you've got all the early implementer sites who have done some of this already, and some of that work's been absolutely kind of terrific, and some of it's summarized on the website in the form of these kind of infographics. So here's one from Frimley, focusing on psychosocial interventions after self-harm, with a 4-session brief psychological interventions, and they've also talked about how they're going to measure impact. Here's one from Somerset, thinking about digital resources. So that's something that's come up again and again and again. Digital resources, how you make sure they're accessible, how you make sure they're useful. So if you like, you've got the early implementer sites to learn from. And this current self-harm work sits with other ongoing bits of self-harm work. So a lot of you will know about sequins. So for those of you who don't, targets for health services that attract incentive payments. And we're really pleased that this year, from April, there's going to be a sequin on self-harm. Now, what we're trying to push for that with that sequin is assessments after self-harm, because we know that not everyone gets an assessment, and it's really thinking about what proportion of assessments by mental health teams are consistent with the NICE guidelines. So what proportion of people who get referred to mental health services, to liaison psychiatry services, get a NICE assessment. That's not the ideal sequence, not the sequence we really wanted, which was what's the proportion of everyone who presents with self-harm who gets an assessment. But I think it was the best we could do. But we can talk a bit more about that. But there will be someone locally will be focused on the sequin and how local mental health services meet the sequin. So very well worth liaising with those. First, in some areas it's the same person that's on the call today responsible for the sequin, but in other areas it isn't. The other bit of work that you'll all be familiar with is the QI for suicide prevention programme that's been going for 4 years now. So quality improvement suicide prevention, funded by NHS England, all 4 waves of the country now covered. And again, we had a similar role supporting with evidence, 3 priority areas: mental health patients, middle-aged men, but also self-harm. So self-harm as part of the National Suicide Prevention Programme, often but not always focuses on hospital settings. But again, as well as, you know, liaising with the sequin team, if you're not those people, liaising with the local suicide prevention team, but again, in many cases, you know, it's people within your teams that are helping them. So I think linking in with what's going on already is a key principle. So you're not having to do this from scratch. There'll be lots of activity ongoing at the moment, lots of other programs that you can link in with. The other, you know, key overarching principle really is the importance here of service user involvement. You know, you put that into practice today from people on the call, but that's really important. We know that improves research, but we know it also improves services. And I work across mental health, but actually service user involvement, developing self-harm services is probably the most important of all, because when staff hear from someone that's been through services, that can have often a very, very profound and long-lasting impacts, and often much more effective than me going on about research, hearing from a service user. Okay, so you've had a little bit of the context. Hopefully you're a bit clearer on where this current bit of work sits in relation to everything else. Let's talk a little bit about settings now. A lot of you will have seen me put this slide up before, the iceberg model of suicidal behaviour, this idea that, you know, suicidal behaviour is an iceberg with suicide at the top. You've got self-harm presenting to services, and then you've got all this self-harm in the community that's, if you like, under the waterline. And really, for the community self-harm project, we're looking at different levels of the pyramid. So it is people on community mental health team caseloads who traditionally won't have got very much access to psychological interventions, people in crisis who might present through the ED, but also people in primary care, people who don't come to the attention of services. So really, if you're thinking about how you might structure your plans, it's thinking about what you provide across each of the levels of the pyramid, and also thinking about inclusivity and involving groups of people who might either be hard to access or have specific needs, or you know, might have other issues in terms of being given kind of psychological therapy. So, you know, black and minority ethnic groups, older adults, people from LGBTQ plus communities, and also kind of young adults too. Just taking one of those groups, people from ethnic minority groups, this is a bit of work that Caroline was involved in, led by our colleague Bushra Farouk last year. This looked at young people from ethnic minority groups who'd self-harmed. So young people from ethnic minority groups who'd self-harmed in Manchester, comparing them with young people from a white background who had self-harmed in Manchester. And basically, these young people from ethnic minority groups who self-harmed tend to live in more deprived areas than their white counterparts. But the really important thing, I think, is that they were less likely to get an assessment. And everyone's supposed to get an assessment after self-harm. They were less likely to get an assessment and less likely to be referred for mental health care afterwards. So, you know, you've got a big problem here with access, which is, you know, frankly, a little bit of a kind of scandal that we've got people who aren't accessing, don't have the same access to treatments as everyone else. So that's obviously, it's very area dependent. For some areas that we work with, this is this is their main issue. For other areas, you know, it's, you know, one of a number of issues. But, you know, really important thinking about access. The other key area, I think, the other real kind of key opportunity to make a difference, to improve things, is primary care. Self-harm in general practice. Traditionally, you know, we've been weak in the UK about what we do about self-harm in primary care. This is a study we did a few years ago, and it's quite interesting in that this won't surprise you. So this splits people by the deprivation of the area they live in, so how deprived their socioeconomic circumstances. And what you see is people who live in the most deprived areas have the highest rates of self-harm. That's really important. So thinking about deprivation, thinking about equity and access to services. But what was, I think, really striking in this study is this group, the people who lived in the most deprived areas, had the highest rate of self-harm, but they were the least likely to be referred to mental health services. So overall, about 15% were referred to mental health services. But this group in deprivation quintile 5, so the most deprived areas, had the highest rates, but were least likely to be referred to mental health care. So that's an example of what we call the inverse care law, so access to services being kind of least, if you like, in the people who are most at need. What might we do to improve self-harm care in general practice? That's a helpful review done by my colleague Faras Mughal from Kiel. So he talks about facilitators and barriers to effective self-harm prevention in primary care. So training always comes up, communication always comes up, following clinical guidance, involving people always comes up, and the barriers will be very familiar to you. So making sure people have access to assessment, local factors and service provision, referral thresholds, that kind of thing. So encourage you to have a look at that systematic review if you're thinking about what are the kinds of things you might offer in primary care. And a lot of the areas already have thought about how they're going to work with their general practitioners locally. The other thing, of course, are kind of educational settings, and I know for some of you this will be very, very, very familiar. Young people don't just present to their general practitioners by any means. Many of them don't present at all. Sometimes, it's families dealing with all this, and there's some helpful resources for families out there. And obviously, other times it's schools, it's people in higher education. Now, the current program, the community services program, that's primarily focused on adults, but obviously that's going to be a spectrum, and there'll be synergies with your children's programs as well. But even if we're talking about over 18s, obviously the university setting is an important setting for self-harm and suicide prevention. Involving voluntary sector, third sector, service user organisations, absolutely vital. We're going to hear about an example of self-injury support being involved in, actually providing services. Harmless are involved in actually kind of service provision, providing services. Samaritans are too. Really crucial. I think this isn't something that statutory services can do on their own. We need to involve third sector colleagues, and there needs to be the funding there to enable them to do that. Okay, let's talk. We've talked a little bit about the context. You've heard about the programme. You've heard about the various settings, community settings, educational settings. Let's quickly talk about some of the evidence. Now, in some senses, we're quite lucky if we're talking about some of the evidence. Sometimes you'll hear there's not a lot of evidence around self-harm. In some ways, that's true, but we are lucky enough to have the kind of self-harm guidelines, the NICE self-harm guidelines, which, if you like, summarise the evidence, and in areas where there isn't the evidence, gives you a kind of consensus view on what we should provide. So I think that's a good starting point if we're thinking about what we might provide for self-harm. And of course, the other thing that comes up again and again and again is competencies, is training. What training should we give to our staff? There's lots of different training courses, lots of different training packages, lots of different training providers out there. A couple of years ago, we did this bit of work for Health Education England, where we really mapped out the competencies. So they're the skills, knowledge, attitudes that we'd expect staff to have when dealing with self-harm. There's one for adults, there's one for staff dealing with adults, one for staff dealing with younger people, and one for non-specialist staff. And it really, you can kind of click on the boxes, and it will tell you what generally we'd expect people to kind of know related to that domain. And what we've encouraged people to do is, if you like, either base their training around these, or in many senses people have got, you know, excellent training already in place, but just kind of make sure they audit the training against the competency framework to look for gaps or look for things that might be improved. So that, if you like, is some evidence or some support material for training. Two big things. Well, the first of the big things that actually helps is making sure people get assessed. So Leah's, who's on the call, has done a lot of work in this area too. Just the psychosocial assessment, just assessing people who self-harm reduces the risk of repeat self-harm by about 40%. And that's important because even now we know only about half, maybe just over half of people get an assessment after self-harm, certainly in hospital settings. So making sure people get assessed. What is it about that assessment that helps? Again, this is Leah's work. It's something about the assessment itself, you know, the humanizing contact, something that's collaborative, something that's kind of reassuring and compassionate, space and time to talk. So it's something about that interaction between the clinician, feeling listened to, feeling heard, but it's also about plugging people into help. So if you do good quality assessments, you can plug people into the help they need. So, you know, just making sure that people get an assessment, I think, is important. That sounds like a really simple thing, but I think it's really important. But access to psychological aftercare is important too. You know, big data slide. I'm not going to apologise for putting up lots of data, because all I want you to look at is this black diamond here. So what this is a forest plot. It summarises randomised trials for psychological interventions for self-harm. And what this forest plot shows is the Cochrane review led by Keith Wharton, my colleague in Oxford. What it shows is people who get a psychological treatment after self-harm are about 34% less likely to repeat self-harm. Often people say, well, what's the psychological intervention? It's labelled in the Cochrane review as CBT-based psychotherapy. Actually, this is quite a wide variety of different things. So there's, you know, interpersonal therapy here, CBT, problem solving. So, you know, it's about something specifically intended for people who self-harm. You know, providing it is the big issue. Up until recently, no area in the country routinely provided psychological interventions for self-harm. I'm pleased to say that's slowly changing now. In some senses, you know, it's about how you provide it. And the other really important thing about if you're providing a talking treatment is when you provide it. And the bottom line is provide it quickly if you're going to provide it. Get in there quickly. Why do I say that? This is data from the MASH project, the Manchester Self-Harm Project, looking at if people are going to repeat, when do they repeat? And the answer is quickly. So 30% of people who are going to repeat within a year do so within the first month. And what this graph doesn't show is that 10% of people who are going to repeat do so within 5 days of turning up. So this idea that we can, you know, send people an outpatient appointment in a month, or, you know, get them plugged into something online within 3 weeks, that's not really going to cut the mustard. If we're going to intervene for self-harm, we need to get in there quickly. Safety plans, something that has come up again and again and again. Widespread use now, popular. You know, I like them very much. You know, all of you will be familiar with safety plans. So something kind of collaboratively developed with the service user, thinking about warning signs, really thinking about, you know, how they cope, thinking about contingencies, you know, where they might go, what support they might have if they experience another crisis, if they feel like they're self-harming again, thinking about professionals and agencies. Some of them, you know, are online, so online safety plans, they're apps. Others in other areas are kind of written. You know, really good idea. It's interesting though that the evidence isn't, you know, quite as strong as you might think for safety plans. There was this systematic review, again, we'll include all the links. Yeah, thought that they were probably good, but it's quite a mixed bag, this. You know, some people with self-harm, the outcomes kind of slightly varied. So, you know, I think the evidence is not hugely strong, certainly in terms of randomized control evidence. You know, another another review also on safety planning interventions. These authors were slightly less positive, saying they're positive studies, but all the studies are a bit different, so it's difficult to kind of generalize a bit. But are they a potentially effective intervention? Yes, they are. Do I personally like them? Yes, I do. But in terms of harder research evidence, there isn't as much as you might think, but a lot of areas are using them. This review is quite interesting because it does point to some of the things that make safety plans a bit more perhaps effective. So making them accessible, making them kind of personalized, involving others, so involving other family members, and making sure it's a kind of collaborative exercise. So it's a bit like kind of assessments. It's a bit like other things in suicide prevention. The what's important, so exactly what domains you record, or exactly what you ask people to do, that's important, but the how of safety plans, I think, is probably just as important, if not more important, than exactly what safety plan you follow. So some pointers there about how, because I know there'll be safety plans being implemented locally. Here are some other resources for how. In fact, Cornwall and Isles of Scilly have been doing some work specifically around safety plans and how they make those more effective. That's the original kind of how-to from the Barbara Stanley and Greg Brown work from the States, and then also some kind of local guides on safety planning. So if you're thinking about strengthening your offer for people in that area, hopefully there's some useful resources. At safety plans, the other thing that comes up again and again, comes up even more now, is the role of digital interventions. Again, it's quite funny in some ways that we as researchers sometimes review the same evidence and come up with kind of different conclusions. So friends and colleagues from Australia thinking digital interventions, yeah, roll them out widely. Other colleagues think, well, actually we need to be a bit more cautious. We need to further understand them. My own view is, yes, they can definitely be effective. Digital delivery can definitely be effective. The principles are the same, but we do need to be cautious. So here's a recent massive study from the States where it was digital interventions, and it was 3 arms: usual care, care management, so online kind of care management where you get assigned a care manager with kind of assertive digital outreach, and skills training. So based on DBT skills training, people were randomized into these huge sample online interventions. What did they find? They found that the interventions didn't have much effect, actually. And one of the reasons for that is that very few people actually took up the offer. So it was online, but it wasn't particularly kind of assertive in a way that face-to-face might have been, and people didn't interact with the offers, so they didn't really take up these interventions, with the result that actually there was no difference from usual care when you're looking at in terms of outcomes, in terms of repetition. In fact, the skills training, it was quite interesting. The skills training was associated with slightly higher risk of future self-harm events. So this idea that digital interventions can't do any harm, can they? Well, maybe they can. So we do need to be cautious. They're not a panacea, but I think they have their place, especially as at times during the last 2 years we've had no choice. We've had to deliver things remotely. So definitely a role, but I think we need to have some caution with point of view of digital interventions. Here's something else we need to have lots of caution about: risk tools and scales. You'll have heard me talk about these. The ubiquitous in mental health, this idea that you can somehow identify people as at high risk. So Leah's work, the work of others as well. What do they tell us? Well, they tell us that risk tools and scales aren't very good. The positive predictive value is about 5%. What does that mean? That means if I rate 100 people as at high risk, the risk tools are right about 5% of the time. In other words, you're wrong 95% of the time. But that isn't the biggest problem. The biggest problem about the whole risk stratification, risk tool thing. It's all the people you rate, or the tools rate as at low and moderate risk, because you exclude those people and you miss people who sadly go on to die in those groups. So it's this idea that risk tools, risk assessment, excludes people. So the idea here is, and it's all in the national guidance, don't use risk tools to predict suicidal behaviour, don't use it to allocate treatment. Just in the last 5 minutes or so, just talk a little bit about COVID-19. Remember, it's difficult to remember back, isn't it? But this is April 2020, seems an awful long time ago. This is what we were all worried about. We were worried about, the indirect effects, mental health effects of COVID being as bad, if not worse, than the direct effects of the virus. What did we learn fairly early on? We learned fairly early on, a study from colleagues in Manchester, that COVID-19 was worsening mental health. So kind of survey methodology, so self-report, all the usual kind of caveats for that. But people's mental health, certainly early on in the pandemic, was about 10% worse than it was before. How did that translate into self-harm? Well, fairly early on, we weren't seeing effects, certainly in terms of presentations to hospitals, certainly in terms of presentations to primary care. So we talked a bit about that. It's early data from colleagues, Sarah Steig and Matthew Carr led this. Actually, this big fall off in attendances for self-harm. This is primary care, national, very big sample. What's that about? That's about perhaps people being told to protect the NHS. It's perhaps about people being frightened. Remember what it was like early on in the pandemic. But also perhaps about accessibility of services, so people hurting themselves, people in distress not being able to access services. But I mean, there is the possibility that like suicide, self-harm fell in the early part of the pandemic. So that this big fall off in help seeking, which I think is the main story there. There is a big fall off in help seeking. This is other data from Greater Manchester, but it's not the same for all age groups. So this is a slightly later study published last year, Sarah Steig again leading it. Just want you to look at the green line. So rates fell kind of in the acute phase for all age groups, but what I think was quite telling is this green group, the 10 to 17-year-olds. We did see a kind of increase in self-harm presentations to primary care. I mean, this only goes up to May 2021, but young people, I think, have been a concern for many of us, particularly from the point of view of self-harm. They've got high rates, but also in terms of their effects on the pandemic. So the bottom line there is a fall in help seeking early on in the pandemic in health service settings. What's happening in community settings? This is data from UCL, and basically it shows that self-harm rates, over the last 2 years in terms of the community setting, according to this study anyway, have remained more or less kind of the same, actually. It's a reminder, this slide, though, that people with mental health problems, mental health diagnosis, have a higher rate of self-harm than people without. But there's not a lot happened in terms of the community rates of self-harm. So what we've got is we had a fall in help seeking to health service settings, no change in community incidence of self-harm. So the question is, are people going elsewhere to seek help? Certainly some of the data we've had from voluntary sector colleagues, helpline colleagues, is yes, that's where people have gone. They've gone online, or they've gone to telephone or text. Here's some data. This isn't UK data, this is international data, which shows that calls to helplines did go up. There's some data from Ireland to suggest that calls to Samaritans increased in length after the pandemic. What's interesting is that quite a lot of this increased call wasn't about suicide, wasn't about self-harm, it was about general worries. But it's a reminder that the importance of the voluntary sector, the importance of the third sector, and the fact that during the pandemic they may have taken up some of the slack from clinical services. Important to monitor this ongoing. So this is Caroline's produced this data, is also on the call. This is emergency department data on self-harm in Manchester. It's slightly kind of crude data because it doesn't include everyone, it misses people. But what we're really looking at here is trends over time. Most striking thing again is this fall off in help seeking in the early part of the pandemic, and then you've got this up and down. You've got kind of possible reductions around second, third lockdown, possible reductions around Omicron. But of course, this also kind of coincides with the end of the year and Christmas as well. So, you know, it's uncertain whether that's kind of pandemic related or just temporal variations, but again, a big fall off. But we do need to monitor the effects of this in an ongoing way. Obviously, some of the longer term effects, long COVID, new variants, etc. But the current, if you like, driver on suicide and self-harm is probably economic, and we know they're some of the most important drivers to increase or decrease suicidal behaviour. So really important that we keep an eye on that, and really important that you keep an eye on that when you're thinking about your plans. So I've told you a little bit about context, the historical context, what a big problem is, how it's linked with suicide, a little bit about a current programme, how it, as part of your community mental health transformation work, should dovetail with QI suicide prevention work, the sequin work for self-harm, talked about, you know, primary care, education, different settings, a little bit about the evidence, especially the importance of assessments and the importance of talking treatments afterwards, and probably not doing kind of risk assessment, which is what we do. A lot of safety plans, I think, be an important part of what you might offer, and then a little bit around self-harm and COVID-19, this fall off in help seeking, but the importance of monitoring things going on. Just want to thank all the people who have worked so hard over the past 2 years back here to you know, carry on producing the evidence and hopefully keeping in touch with you guys. First up is Louise from Langston, South Cumbria. So take your time, and we can, you know, well, I think we'll save the discussion for the Q&A, but do take your time, Louise, and tell us what we need to know. Over to you.
Okay, thanks for that. Thank you. Can you hear me okay?
We can.
Yeah. So I can't share my screen for some reason. It's been disabled.
Louise, I can very quickly add you to do that if you like, and otherwise if it doesn't work, I've got a copy and I could present for you, but I'll just try and add you now and you should be able to do that.
Thank you.
You should now have permission to do that, so I'll just leave you to have a go.
Yep.
Okay. Can you see that now?
Yes, we can. Perfect.
Wonderful. There we go. Okay, so obviously I'm from Langston, South Cumbria. So just a bit of background as to where we are with our sort of suicide prevention and self-harm programme. Helen's on the call and will come in a little bit as well. So across Langston, South Cumbria, we have a suicide prevention logic model. This is just the sort of front sheet of that logic model, and what sits behind it is a number of actions. We identified self-harm early on because we were one of those first sites for suicide prevention funding from NHS England. So we've been working around self-harm for quite some time, really. So that's just to highlight our logic model. What work we've got underway.
Louise,
yeah?
sorry to interrupt. I'm just wondering, the slides are a bit small on my screen, so I don't know if you want to go into slideshow view.
It's on slideshow view on mine.
Oh, right, okay. That's fine, probably just my screen then. Might just be my screen.
Okay, well, apologies about that.
No worries, don't worry, that's fine. I'll just try and I'll make my screen bigger. That's fine. Sorry, I'll shut up now.
Okay, no worries now. So in terms of what work we've got underway, we have a well sort of rounded real-time surveillance data system in Langston, South Cumbria, which we established back in 2018. We've now sort of broadened that, and what we're receiving in real time is self-harm and attempted suicide data from our NWAS colleagues. We're using that to make sure that we are an intelligence-led system, and that we're using it to improve, you know, to develop our improvement plans across all areas of the system. I mean, we've got Marie on here from our public health colleagues from
Louise, I'm really sorry to interrupt again. all I can see is the logic model. Have you advanced the slide? Because I reckon we're probably seeing something different to you.
Yeah.
All right, now it's moving.
I think when it goes on when I'm putting it onto the full screen, it's not doing it.
All right, okay.
It's Zoom. You really shouldn't use Zoom. You should use Teams. But anyway.
Do you know what, Louise? We shouldn't use any of them. And actually, it would be much nicer if I was visiting you face to face. But there you go. We're stuck with it. So we're on self-harm workstream progress at the moment. Is that the slide we should be on? Okay, thank you.
That's right. Yeah. Sorry. So as I said, we now get self-harm and attempted suicide data from our MWAS colleagues, and in slides a little bit further on, I'm going to showcase some of that data and what that looks like. We've also completed the 10 safer care standards, which obviously you guys lead from NKISH, and we've done that on an annual basis with our trust colleagues. And then from that, we use it to develop improvement plans, and obviously self-harm forms part of that 10 safer care standards. I'm going to let Helen talk a little bit around the self-harm task and finish groups that she's established.
Okay, thanks, Louise. So the self-harm steering group has a good representation across the footprint, really, from all members. So it has a good representation from primary care to grassroots community groups that all come together to really shape how the self-harm work is being carried out. So for this year, we've developed the self-harm practice guides, which is to support all our community groups. So we've just finished our 3 practice guides, which are focused on children and young people, adults, and professionals and all agencies, so that we can really raise the awareness of self-harm, why self-harm is there, what the context is, obviously the same as some of the areas that we've covered today, but really to push that through all of the sectors that we're working with. We've obviously supported those guidelines with the knowledge that we need to make sure that everybody has the resources that are applicable to their areas, so that they can support people that they come into contact with. So we've made sure that they've all got localised and national helpline resources. All of this obviously aligning with the NICE guidance, which lovingly will change in a few months, and we'll have a nice new piece of work to do again, but all for a good cause. The resources themselves, obviously with the competency frameworks, has been looking at training as well, so making sure that people have the skills and competency to support people, because I think that was what the self-harm steering group was really identifying, is that they needed to make sure that people were confident to be able to support people in the same way, and obviously to start to be confident with those conversations. So we've been putting a lot of work behind the training side as well. So we've commissioned some harmless training at level 2s and 3s to roll out across the footprint, to support these practice toolkits. Within Lancashire, we've been developing the self-harm safe kits, which have been co-produced with people with lived experience and professionals across the footprint, and they're just being analysed and hopefully being produced and released in the very near future. So that's been something that was developed originally in Cumbria, and that we've obviously lessons learned and moved forward and been able to work in partnership with Every Life Matters to make that happen. So there's been some really good partnership working and some good practice that's been kind of shared. Is that back to you, Louise?
Yeah, we've also got a huge suicide prevention campaign, which we've been running since the start of the pandemic, really, making sure that our local communities are aware of the support services that are out there. And our next phase is around CYP. It will also include things around self-harm advice, etc. And it'll link with those self-harm kits, which are being developed in partnership with Lancashire Mind. We're working with the trust around a discharge pack, making sure, I know Nav, you sort of mentioned safety plans, that will form part of that discharge pack. It'll include information, services to access, etc. And that will be given to anybody that is discharged from community. So it aligns with the 10 safer care standards in terms of, you know, that they're aware of what's available, that their, you know, families and carers are included in it. So that work is well underway and hopefully near complete now. Our police colleagues work in partnership with LSCFT. You know, they're right on the front line, our police colleagues, and feel a lot of demand. So they, you know, we have street triage and synergy cars out across our area, and they are working with people that are obviously self-harming and looking at how we join those dots together. And we also have a frequent attenders team as well to support some of that work. Examples of some of our RTS self-harm reports, and I apologise because if your screen's small, you're never going to see this anyway. Well, but you know, I will share this updated version. We do now, we're able to profile all of the NWAS demand. We get this data across the whole of the Northwest. We get it on a weekly basis. And we're able to, you know, produce profiles in terms of, so this little chart, which will be absolutely minute, so apologies about that. We can map days of the week. We can see when our biggest demand is for self-harm. We're able to map type of self-harm. That the most common is around threatening suicide. The way NWAS code their data, they used to have about 50 different, well, about 100 different codes for self-harm. They have changed the way that they are coding currently. So it will change the way our data looks. But, you know, we're getting this data across all ages. And what we're trying to then do is triangulate that with other data sources that are within our communities, within the crisis teams, with our schools, to then really build up a picture of where the pressures are within our system, a heat sense of areas that we need to target, and just become more intelligence driven. In terms of the CMHT transformation work, as sort of you said, Nav, it's around making sure it's within that community. And this is an example of the model that is being adopted across Lancs and South Cumbria. The IRS, which is the initial response service, is very much crisis focused. You know, there will be no wrong door. Anyone will be able to access the IRS teams, and then they will be either transferred out into the voluntary sector, or they will be then put into their primary care networks and locality sort of community services. As I said, this, I mean, it aligns with the CMHT transformation, and work is, you know, this is starting. It is a big journey. It's a lot of work to do, but hopefully by the end of the programme of work 23-24, you know, we will see a lot more of our services deliver locally in the community and accessible to all that need it. What are our next steps? So again, looking at the intelligence, we need to do a self-harm audit. We did one about 4 years ago now. Obviously things have moved on, and this will then feed into that CMHT, the crisis transformation and liaison services as well. As we've said there, we're improving access to frontline primary care services, making sure that we're identifying problems at the earliest opportunities, you know, to reduce the escalation risk for individuals. You know, I'm not going to read through all of them. You can see that yourself. So, you know, I think we're moving in the right direction. There's lots of pressures, vacancies, you know, recruitment of staff, but it's how we work together as a partnership and a system with our voluntary sector organisations, and making sure that we're getting patients at the right time and in the right place, and they're being seen by the right people. So that's a very quick overview of the work that's underway across Lancs.
Right, so I'm going to hand over to Kat next, who's going to give us the view from Bristol, North Somerset and South Gloucestershire.
Now I will try and play with the screen sharing and hope it works.
Yeah.
I've only got one slide though, so technically I'm hoping it should be.
Yeah, no, so we were really mean, and we had rules, which was only one slide.
Perfect.
Which I'm pleased to say that Louise, you kind of ignored, but that's fine because it was really interesting. But that's why Kat's got one slide, but I'm sure there'll be lots here that we can talk about.
So I would say what we've just heard from Lancs and South Cumbria has been really interesting, and made lots of notes of stuff to learn from that, because I don't think we are quite as developed as they are. But we do have some stuff going on. I think the first and most exciting thing that we developed during when we first went into COVID, and we had some COVID monies come through, and what was going on, what we were expecting to happen, as you were saying earlier, with increases, we were expecting that increase in ED attendance, expecting that self-harm. So we set up very quickly, with the help of Self-Injury Support Service, and Jess can tell you more about this later, is our ED referrals self-harm service. So this service was set up and established in December 2020, so quite quickly. And it is designed for people who are attending ED, having self-harmed, who are not known to secondary care services, and not meeting the criteria to be referred to secondary care services. So it's all those people who attend ED and are discharged back to their GP with no support, for want of a better word, apart from being patched up and sent back out again. So the service is peer-led, and they, within 72 hours, they receive a call from the SIS service to book an appointment, which is then booked within a week. That appointment can be face-to-face, video or telephone, depending on circumstances where we are in COVID and what the service user needs. And that's then a one-off 1.5 hour appointment with one of the peer-led workers. And it's to talk about whatever the service user wants to talk about. So if their trigger for self-harm, it relates to debt, they can talk through debt worries, they can talk through wound care, they can talk through anything that is what they need to talk about at that moment around their self-harm. There's then a 2-week follow-up from that, which is like a 20 minutes, half an hour call, just to see how they're doing, whether they've used any of the advice that's been used, and then a 3-month follow-up evaluation. And as we know, that doesn't get responded to as well as we'd all like. But we have we've just had the first annual report come through, which is amazing. We haven't had as many referrals into the service as we had expected, and I think there's some work going on to see why that is. And I think it's a lot of it's about the fact that potentially people going into ED are already known to secondary care services. So we are looking at whether there are more ED referrals coming in, but there's been, and I'm remembering this off the top of my head now, I think about 130 service users have been through the service since December. And again, this data needs to be validated, but we, on initial review, think only 3% of those have ended up back in ED since their initial referral, which is incredible. So we have recently agreed to extend the funding of this until March 2023. And we are expanding, we're working with the EDs to get more referrals in, but we're also looking to expand those referrals to walk-in centres, urgent treatment centres, and potentially also IAPT. So again, the people who ring IAPT but don't meet the threshold for IAPT services and would normally be referred straight back to GP with nothing. So potentially in there as well, and potentially other areas that we're growing it slowly so we don't swamp the service. We are absolutely aware that primary care and GPs is possibly one of those areas we want to expand it to eventually. The service would need to be a lot bigger than it is now to be able to cope with that. And it's one of the things that we're looking at through the Community and Mental Health Partnership framework work to grow that. And that's the reason the funding is till March 23, because hopefully it eventually will be part of that wider piece of work. So Jess can tell you more about that later on if we've got time. Other things that we've had going on. So in Bristol, we've had the emergency department self-harm register for about 10 years or so, and it is got some amazing data in there. It has had intermittent funding that has been sort of 6 months and a year, and there's always this battle for ongoing funding for it. And also there's been a bit of a conversation recently about how it's used and whether it's collecting the right data in ways that is usable for services. So there's currently a options paper being drafted about the future of the ED self-harm register. So we're very much hoping that it will be able to be sustained going forwards, but also in a really usable fashion, potentially looking at some of that real-time work or ways of being able to tell us what's happening for some of those services going forward. So hopefully we will have some more information on that in the coming months. All three of our local authorities are in various stages of currently doing self-harm joint strategic needs assessments. So some are almost published and some are just gathering the data. So they're all in the process of that. So that will also tell us more about what's going on in our areas and where we've got services and gaps. And I know one of the really exciting things that I think South Gloucestershire have done or do on a regular basis is a online survey of all primary and secondary students. And they're currently analysing that data, but the initial data suggests approximately 25% of students have self-reported self-harm in the last year, which is huge information and will run through what happens next. So specifically looking at those children's and young people services, there's a lot of work currently ongoing to gather data, identify the needs and gaps in services. And I think that's where we are with our children's and young people services, is identifying that. However, I did have an email from them this morning, so I've slotted it in to say that there is some new BNSSG self-harm guidance for schools, which has now been adapted for non-school settings. And that is available on the Healthy Schools website for Bristol. So I can share that link if that'd be helpful. That's sort of an initial starting point. And then, as I say, we're sort of identifying needs and gaps. I think we are seeing, or initial data suggests we're seeing a lot more people coming through our children's ED. So just really identifying what's driving that, what that looks like and what we can do to support that. And I think all of those things that I've talked about, what big thing that they're doing is identifying the early gaps and what we need to do next. And the peer-led service has been really, really good at kind of identifying where they've got people coming to talk to them about certain things and whether they don't have the resources to be able to, that there's no sort of self-harm support groups in North Somerset that are meeting face-to-face at the moment. Some of them stopped because of COVID, some of the, so we're then talking to our North Somerset public health team about some funds they've got and whether we can direct those in the right direction. We've also identified that we need to increase our links with our LGBTQ plus disability and minority ethnic mutual aid groups, because they're areas that we don't have massive amount of support and information from, and also specific support for men that self-harm. I mean, obviously CIS's background is in supporting women, although the service they provide is all gender and 18 plus, that following on from that point, that there's not a huge amount for them to refer on to. So those are the ones that we've sort of identified as early gaps now. We meet, the BNSSG Suicide and Self-Harm Prevention Group meets on a monthly basis, and we're setting up a rolling programme so that we talk about suicide prevention, children and young people, and self-harm on a rotating basis, because I think it's been quite easy in the past for self-harm not to be one of those priorities. So we're making sure that at least on a quarterly basis, we're making sure that we progress where we are and know where we are.
Jess, we'd be really keen to hear a bit more about that. I suppose in particular, what actually happened, what's it like? Because I think it's such a novel service that I think a lot of other areas could learn from. So sorry to put you on the spot, but I'm wondering if you can tell us a little bit about how it works.
Yeah, absolutely. So the service user journey is essentially we receive a referral in from one of the 3 EDs across Bristol, North Somerset and South Glos, hopefully expanding to other places at the moment. And that's picked up by our team. And within the first 72 hours, we give the person a call, or some people prefer text. So we text them, get in contact with them. And then we find a time within the next week. Sometimes it goes over a week if the person's not available, but everyone's offered an appointment within that first week. So it's pretty quick intervention. the appointments are really great. Like Kat said, it's really client-led, so it's definitely that we don't really prescribe what we want to do. It's about what the service user brings to us, what they want to explore. You know, often people might want to kind of understand what their self-harm is really about. So we're quite, as an organisation, you know, we do lots and lots of work around trying to really like pinpoint what is going on with self-harm, what the reasons are, what the functions are, and then off the back of that kind of identify resources, identify tools, distractions, whatever people want, to maybe help manage that. So that's quite an interest. I think that's a really useful approach that we do take, which is very tailored to the patient. Yeah, then it's a real, I think that's, for me, I think that's a real benefit of being able to have that one-to-one hour-and-a-half time, because it really allows that person a really personalized experience. And then anything that we then like give them resources, information, refer on to services, it's all very much tailored around what the patients brought to us and what they've wanted to talk about and explore. It's peer led, so everyone, we all lived experience on the project. So I think that we collected loads of really lovely feedback actually from service users, and it's just overwhelmingly positive, particularly around lived experience. And that I think I've got it open somewhere on my computer. So we do like a 2-week feedback form, which we get quite a few more responses to. The 3-month one we don't. Yeah. But you know, a one-off service that you meet once, 3 months later, you know, it's not surprising that we don't get a lot. But the 2-week feedback form we do ask people to complete at the end of our follow-up appointment. We do get a fair few responses to that, which is pretty good. And of the people who did respond last year, 87% of the people who responded said that they were more inclined to come to the appointment and engage with the service because it was peer-led. And actually, it was like 91% of them said that actually being in the appointment with someone who was lived experience in a non-clinical setting was really helpful for them to explore their self-harm. So I think the evidence for the impact of lived experience has been really amazing as part of the work that we've done.
I've got so many questions, Jess, and I'm just gonna take a couple of them just for clarification. We can have a wider discussion during the Q&A. So the first thing is you'll give them a kind of quick call. Has there been any difficulties with kind of contacts? Because that's one of the things we've found from time to time, that actually you can't get through to people, you're not getting right numbers, etc. Has that been a challenge?
Contact with every referral we've had, the contact details, with a couple of exceptions, have been pretty on point. So the staff have been really good at referring in with the correct information. Some people are a little bit hard to get hold of. I think in total, it's for last year, I think 11% of the referrals we actually couldn't get through to at all. But that's pretty good. We still managed to get through to the rest of them, which is a pretty high number. Yes, not everyone answers immediately. So the 72-hour turnaround is great, and everyone gets contacted in that time, but not everyone will answer the phone. And sometimes you might have to send a text or send an email to someone. And people just email back and get in contact, because I think people just don't like answering the phone to a number.
9 out of 10 is absolutely spectacular if you're getting hold of 9 out of 10 people. And can I just check, is the contact face-to-face or virtual, or does it just depend what the person prefers?
It's up to, we let people decide what they want. So we offer face-to-face, but we can also do Zoom or just a phone appointment as well if people don't want to do that face-to-face work. I think there's benefits to all different forms of that. So we just let the service. The
intervention itself, it's an hour and a half, and it's quite kind of practically focused. So, you know, it's about the things that matter most to the service user. And then if it sounds to me like the interventions are kind of quite practically focused, like signposting to resources, that kind of thing. Is that right?
Yeah, absolutely. And the support workers that the team are absolutely fantastic. They're really brilliant. And we've got a huge ton of different resources that we kind of draw upon in appointments, and their team is so good at sort of tailoring those. And sort of, you know, you might get a big document, a big resource that's really helpful. They'll pull out the couple of pages that they know are relevant to that person, that feel the most appropriate at that time. So it's quite resource driven as an outcome, but it's also a really sort of open and gentle space to be, you know, explore emotions, explore feelings. And you know, we've got so it's kind of a nice mix of the two.
Yeah, and I suppose the other thing that you must get asked, and is the obvious thing is, what training and supervision do the peer support workers actually get?
Yeah, so we did a lovely 2 weeks of initial training at the very start of the project, and we do ongoing kind of refresher training. So alongside this project, I also manage our national helpline. So sometimes peer support workers will come to the volunteer training just to get the other side of just pure listening support and how that looks and how that works. So there's sort of lots of sharing of knowledge across the organisation. And all the support workers, we all get one individual clinical supervision once a month, and we run reflective practice sessions as well amongst the team. So there's lots and lots of support to make sure that everybody is safe and happy and able to manage that.
Just so pleased that you've managed, Kat and yourself, and I'm sure many others have managed to get kind of funding through to 2023. That is really terrific. I mean, in terms of obviously ensuring longevity, it sounds like you've got your heads into the kind of evaluation thing. I think people are going to be very interested, especially there was a hint there that repetition rates were quite low, and if you can show that, I think you're really hopefully
it makes it much easier to get funding if you can show the impact on ED.
Yeah, no, I think that's terrific. And the only other thing, Kat, just wanted to pick up with you, really, thanks, that was really excellent. You summarised it all in one slide brilliantly. I know the other bit of work that is going on, and I don't know how directly linked you guys are with that, is obviously, you mentioned school, but it's the university setting. So no,
yeah.
So University of Bristol, University of West of England, it's Bristol focused rather than Gloucester and Somerset, but presumably you've got links in there because they're doing loads, aren't they?
Absolutely. Victoria, who's on the call but listening because she's in a public space, so can't join to say anything, is leading that work with the universities and the local authorities. So
because in many senses, I think a lot of people around the country look at you guys as the kind of trailblazers in terms of self-harm in that higher education space. So absolutely terrific. Well, I'm greatly inspired after those two talks. Thank you very much indeed. Right, so we've got some time for questions. Caroline's also been keeping an eye on the chat. I've got about 1 million questions, but I'm going to shut myself up now. And over to you. So questions, raise your hands, put stuff in the chat, whatever you like. Okay, while you're thinking of questions, Caroline, was there anything that came up in the chat?
No questions in the chat.
Okay. Okay, while people are kind of thinking of kind of questions for each other, about, I suppose I think there have been a few things here that have really kind of made me sit up and take notice, because it's not, I haven't heard it to the kind of same degree in the many other areas we've visited, definitely the peer support, but then from our LANCS colleagues, it's about the real-time surveillance of self-harm, actually, which, I mean, real-time surveillance of suicide is difficult enough, and of course, many of you know that LANCS are the kind of one of the trailblazers there, and contributed to the NKISH kind of real-time surveillance papers and outputs early on in the pandemic. But I'm just wondering if colleagues might want to say a little bit more about the self-harm real-time surveillance, relying on the so it's the North West Ambulance Service data, and how that's working, how reliable you think it is, and how you're using it.
Do you want me to put up one of the reports that we produce?
Yeah, go for it.
Okay, let's just see if I can. So as I said earlier, we get, hopefully that'll work. Hopefully it's fuller screen. Can you see that?
Yeah.
Yeah. So as I said, we get a download from our MWAS colleagues on a weekly basis now, and this feeds into our real-time surveillance analysts. We collect the data across the whole of the Northwest, so it's not just LANCS to South Cumbria. We also have it for Cheshire and Merseyside and GM. So what we do with the data is we're aligning it with our RTS suicide, suspected suicide information as well. We're splitting the data in a number of ways to feed into different governance structures that are being established in the ICB. So this is based on those that are ringing 999, looking for a 999 response across our Northwest system. So the data in front of you here is for under 25s because of the way we've split it for our governance structures in Lancs and South Cumbria. So we've cut the data 0 to 25 to support the transformation work with CYP services, aligning to the NHSE long-term plan. We've got it from 18 and above, so there's a bit of double counting in some of this data because we've counted 18 to older adults, and then we've cut it 65 and above as well. So what we get is the how NWAS are coding the information.
Yeah.
So you can see there, as I said, there's about 150 different codes within NWAS. Every ambulance service is slightly different. So, you know, our biggest area for our 0 to 25s is threatening suicide, intentional overdose. You know, we can see it where they've tried to resuscitate, where people are dead on arrival, etc. So it's really, you know, valuable data.
Louise, because I'm a boring researcher, I'm just going to ask some boring research questions, but they're important in terms of what the data means. So how is that data coded? Is it me, if I'm the paramedic attending, I'm entering a clinical code into the system?
It's the call handler on the call, and then you'll have a stop code at the end.
Okay, so I'm the call handler and I get a call through from someone to say, yeah, I'm feeling really bad and, you know, I've taken some paracetamol tablets. I then code that on the system, do I, as a call handler? And can I just ask as well, obviously you've got the intentional overdose codes there. What about injury codes? Do they have, you know, if someone's cut themselves or something, would they have those as well? Or
yeah, they have that as well. They have like ligatures. They have that. You know, it's a vast. We've got a whole data set. So you know, Nav, we can share that with you, and you can have a look at it.
But it's the call handler making the judgment about, and they're taking that directly from what the caller has said, basically, aren't they? So.
Yeah, and then you have the stop code at the end. So it's, you know, where you have see and convey, see and treat, hear and treat. So we understand. So as a system, we can say, well, I'll show you here. We can see the volume of people that are being conveyed to into A&E. So of those 0 to 25-year-olds, over 2,000 were conveyed into our acute setting. We can see the volume that was seen treated at home. This no outcome is a bit of a red herring, because actually when you break that down, you can then really unpick. You might have police dealing with the incident, so we can see the demand on our police services. You know, so that one, you know, we always flag that and say there's lots, you know, we need to unpick that overall code. And then we can see, we break it down by the category of call as well. So a Cat 1 is a life and death situation. A Cat 2 is normally a 17-minute response time. Obviously, during COVID, that was dramatically increased. And we have that across the board. We split it by CCG area. So it's all about supporting those improvement plans, looking at our demand. Where do we need to put more resources? What we do want to do is cross-correlate this information with the acute data. You know, are they coding it correctly, etc. So we can do that triangulation. Helen's working with the schools, because what we want to be able to do, we have Operation Encompass across the Northwest. So when there's a domestic violence incident and a child is involved, the schools are notified. What we're trying to do is see if we can extend that for self-harm. So when somebody, like a young person, self-harms, can we then notify the school? Because obviously the school is a really vital support system that we can actually access other mental health services. So that work's also underway as well. But that's how our data looks. You know, we're able to then look at you know, how we want to use this. So for Cheshire and Merseyside, for example, I'm using this data for looking at crisis, looking at our crisis services, looking at bringing this into our as capacity and demand, making sure that our 24/7 crisis services are adequately resourced to meet the demands, because ultimately those patients that are sat waiting in a Cat 3 to Cat 5, they don't need to be in an MWAS stack. They should be coming into a mental health system. They should be, you know, being addressed by those mental health practitioners and taking that demand away from our NWAS colleagues. So that's the way that we're starting to use the information. We can map it because it's non-patient identifiable information. We've now extended the postcode, so we're getting 4 digits or 5 digits of a postcode, so we can start mapping it as well, because that was a recent change. But it's really good.
It's brilliant. It's really brilliant. Is that something that every area of the country would have, you know, that have the data from their ambulance service, or is this particular to North West Ambulance Service?
I'm not aware of any other area that has it.
Okay.
We've obviously got great links with Craig and you know, in NWAS, and we've worked with them on this. You know, I think being one of those first areas within the suicide prevention programme has really helped us to move the RTS data forward, and that's why we're then adding other data sets into it.
I think it's absolutely terrific. I mean, I think your you know, the use for you guys locally is, you know, you've talked about, well, it's about planning, it's about resources, it's about kind of targeting, it's about, you know, in some senses possibly taking some of the pressure off North West Ambulance colleagues if people can be diverted. I suppose from my point of view, it's really, really interesting as a almost kind of independent data source, you know, when people ask us, are rates going up or not, you know, monitoring trends, and also linking it with other stuff, because presumably that, I mean, I suppose it's anonymized when you get it, but does the ambulance service data talk to the hospital data, or is it one of these things where actually they're you know, it's more a standalone system?
It's a really good question, and they're the things that we're sort of exploring a bit more, because when we've presented this to our so for example in Cheshire and Merseyside, when I've presented it to the mental health trusts, they're like, that data doesn't look right to me. You know, that's not the number of people that are coming through the liaison services within the trusts. So I think there's probably a coding issue, or how when they get into that A&E setting, it's then picked up and coded within A&E. So, because all the codes are different, and as I said, so I know Yorkshire Ambulance, Yaz, they've got a different coding. So they all have different coding, and it's how you unpick it, really.
Caroline, you could talk for weeks on coding, couldn't you?
Well, actually, the clinic we have on Thursday, I'm doing a presentation on coding for self-harm. So if anybody is interested in that, then come to our clinic on Thursday.
Yeah, so Thursday we'll have one of these events that's open to all the sites across the programme. So you get less personal kind of interaction, but hopefully that the coding one will be of some interest. Kat?
I did see that one. I've got something in my diary already. But I have sent it to one of my BI colleagues. I just wondered, is there a list of those clinics and what they're going to be and when they're going to be in advance? Because I know that some people are just struggling to, when they hear them at relatively short notice, to put them in the diary, whereas if we know them in advance, we can get the right people to them.
Leah's just unmuted herself. She's prepared.
Yes, I am, and it is something that we're literally doing right at the moment. So we've got meetings planned up until November. So we will finalise the speakers for those, and we'll get it out in the next week, and then people can kind of allocate which ones they want to go to and stuff.
That's amazing.
We're doing, sorry,
Sorry.
We're doing a kind of theme with you know, various speakers and things each week, but they're actually an opportunity for you to ask any questions you have at all. So we have you know, you can email us beforehand if you have a specific thing in mind you want us to sort of reflect on beforehand, so that we can bring some information for you, or you can just come on the day and ask any questions at all.
Yeah. Helen's just asked if you can share details with her about the Thursday meeting, please. And I've had a look at the program for these virtual clinics, and frankly, they look a lot more interesting than anything you might get from me. So well done, Leah and Caroline. You know, lots of kind of quite topical things. I think, you know, primary care is one, isn't it, Leah? And data.
Yeah, that's the main one.
So it's going to be absolutely tremendous. Marie.
Yeah, sorry. Just to say that obviously we've used some of the data from the real-time surveillance, and also in Lancs, and also some of the suspected suicide data with regards to looking at some of our structures. So we've got what we call a high-risk location with regards to a bridge, and it's been really useful to use the police data, but also once we've had a location identified, because it hasn't fallen under the national highways, for example, it's under our localised approach. It's been really useful to be able to engage our district councils, and it's not necessarily been on their agenda previously, even though that we've got mental health issues within their area around suspected suicide and young people using this location, for example. It's also near a refuge, so we've had people with tendencies to walk out from the refuge and go to the bridge. We've had some really good responses in regards to that and engaging the district council, to be fair, and they've actually put it on the health and wellbeing action plan now, which is great because we've gone from nothing to everything with them. So it's quite intense, but I think it's just an alternative way to sometimes use the data. We've actually managed to have the structure of the bridge changed, not dramatically, I must admit. It's not gone to an overarching parapet or anything. It's just a rise in the actual fencing itself. But also it's brought on our highways agency and have opened up conversations with them around public health approach, around guidance. It's opened up some of the media guidance. Lou's teams mentioned done some media training previously, which is, some people take it on board and some people gallantly ignore it, which is absolutely ridiculous, but and frustrating. So systematically then we're being able to engage our elected members as well with regards to conversations and language, and really challenging the actual way that people are talking around suicide, to the point where we've used the RTS data to look at some of the areas. So we've had one area that was not got a high population. It wasn't a city. It was in the top 5 for the first year, and we approached the council there, had conversations with them, and they really welcomed the actual data, because they know other areas are talking about, oh, we've got an issue in this area, and we're saying we've actually already dealt with it.
Yeah,
Council know about it. We've used the RTS data. We've engaged emergency services, police, GPs, and more, I think more to the fact, communities. They've really welcomed it as a systematic approach. So we've used the logic model plan. We've talked about attempts. There was a high-risk location there with the school, unfortunately, that's it's really helped us to address with the school. And communities are now talking about self-harm and suicide, which it's, if you will, it's kind of an industrial town that's quite old, and it wasn't something that was really talked about. I know that obviously through COVID it's been exacerbated with mental health, for example, but we've had some really good response from it. And it's quite, having the real-time surveillance data to be able to say this is the here and now, has really made action rather than just conversation. So yeah, we've used the self-harm data as well to try and overlay that, to say you might not be seeing these numbers coming through, but actually you do have an issue, which has proved really
That's brilliant. That's brilliant, Marie. So I mean, I think from Louise we got using the real-time data, kind of shaping services. I was talking about it, thinking about trends and stuff. And Marie, you've actually given us another, the other thing about the real-time surveillance is it started conversations and actually action for you locally, which I think is absolutely tremendous. I'm conscious that time is moving on. We are definitely not going over time, so I'll give the last word to Kat.
I was just going to say we also have a bridge in Bristol.
Of course.
So we have a specific subgroup working group that's specifically about the bridge in the gorge.
Yeah.
If anyone wants any links, if you've got issues with the local bridge, we've been working on that for years, and we have to the gorge because of the work that's happened on the bridge that's been successful. Unfortunately, we've a mover problem potentially.
Yeah.
If you want to link with what we've done and some of the stuff that has been successful, I'm happy to share those links.
Brilliant. Thank you so much, Kat. Thanks everyone. We've got 2 minutes to go, so I'll just kind of sum up and end there. That's been really tremendous actually, and sometimes in these meetings we come up with some real kind of nuggets that need to be shared more widely, and I think we've had that today with the peer support, the real-time surveillance, but also lots of other things. Stay in touch. We'll be in touch with you guys via email. Please do come to the kind of virtual clinics and things, and there'll be other things around about that you can quiz us on, and feel free to ask us your questions. So there's a generic email address, but that gets through to us and it will go to Leah or Caroline or myself, and we do our best to answer questions. But fantastic work. I'm really inspired. Thanks very much for coming, and see you next time.